Hi, my name is Brian Apavu. I am a neurologist with an interest in philosophy, the mind, and living the examined life. Today, I want to dive into childhood absence epilepsy, a fairly common epilepsy condition that I see in children in my historical clinical practice. Now, to just start, I want to start with a general disclaimer. This is medical education. This is not medical advice. If you have a need for medical advice, I would discuss your issue directly with your clinical provider. Childhood absence epilepsy is an idiopathic generalized epilepsy syndrome, typically presenting in children between 4 and 8 years of age, and it accounts for about 10 to 17% of childhood onset epilepsies. It's fairly common. When I describe what I refer to idiopathic generalized epilepsy, that means it's an epilepsy condition that we think is genetic, although we don't necessarily have identified the target genes or constellation of genes that manifest with the syndrome. Now, the classic manifestation of childhood absence epilepsy is a child who has frequent absence seizures. These are what we call staring spells. It's a sudden behavioral arrest that a child might experience, and it can be accompanied to what we as clinicians call automatisms. What are these automatisms? They might be something like when the staring off occurs, there's a little bit of eyelid fluttering. There could be lip smacking, like a something like that. And these seizures typically last about 5 to 30 seconds in duration. They often don't necessarily manifest with the jerk or any convulsive activity, just the staring with the lip smacking or the eyelid fluttering. And these can typically last 5 to 30 seconds in duration, although there are cases where it can go on for very long periods of time, up to several hours. But most of these are about 5 to 30 seconds, and when they occur about a dozen to 100 times daily. Oftentimes families might say that they notice it, 5 to 10 times a day. The teachers at school might notice it a couple times a day, but if you actually put these patients on EEG for a full 24 hours, if they're untreated, they could be having hundreds a day, and only a few of these are really noticed. The EEG of patients with childhood absence epilepsy shows a generalized 3 Hz spike and slow wave discharge activity with a normal background. Now, these runs could be in brief durations of a couple seconds or half a second, where there's no necessarily there isn't necessarily a clinical accompaniment. They're not staring with it. That's obvious on a video. But when these tend to be longer, they're often associated with some form of staring off and behavioral arrest and so forth. The pathophysiology of childhood absence epilepsy and the absence seizures with it involves abnormal thalamocortical circuitry, which underlies the characteristic EEG and clinical features that we see with absence seizures. It centers on abnormal oscillatory activity within that thalamus cortical circuitry, which produces that 3 Hz spike and wave pattern that I described. The circuit involves 3 neuronal populations: thalamic relay neurons, thalamic reticular neurons, and cortical pyramidal neurons on the cortex. During normal wakefulness, thalamic relay neurons activate the cortex in a tonic mode in terms of their firing. But during absence seizures, these neurons switch to a burst mode facilitated by T calcium channels and modulated by GABAergic inhibition from the thalamic reticular nucleus. So let me rephrase that, the thalamic reticular nucleus. So this is what sort of leads to that alteration of consciousness that we see with the absence seizures. And if you watch some of my videos about disorders of the consciousness, we know that the thalamus and thalamic firing, as it relates to thalamic to burst firing or to tonic firing, really plays a role in our experience of consciousness in terms of the brain. Recent evidence demonstrates that both cortical and thalamic mechanisms are essential when it comes to absence seizures. The spike component of the EEG discharge is driven by thalamic input to cortical microcircuits, while the wave component on the EEG arises from the intercortical oscillations, reflecting a dynamic interplay rather than just a simple thalamic pacemaker. Dysfunction in AMPA receptor mediated feed-forward inhibition and altered GABAergic signaling further contributes to the hypersynchrony and impaired consciousness that these children experience during the seizures. Functional connectivity shows that during the ictal generalized spike and wave discharges, the thalamus exhibits strong connectivity with cortical regions involving consciousness, which explains the disrupted behavioral arrest. The severity of the absence seizures in childhood absence seizures is often underestimated. While most children are otherwise healthy, childhood absence epilepsy is often associated with significant neuropsychological comorbidities, including attention deficit, executive dysfunction, and academic difficulties, which may persist even if you have good seizure control. Quality of life is variably impacted. Many children may require special education and have increased risk of psychological comorbidities like ADHD or sleep disorders, and others may be perfectly fine. We do think that the seizures contribute, the seizure burden contributes to the impairment in terms of learning and attention, and so we want to treat for that. Although there are studies that show that even when the seizures are under good control, some of these difficulties can arise in terms of academic performance. There's important, in terms of treatment, there's an important landmark double-blind randomized controlled trial that was published in New England Journal of Medicine in 2010, where 3 medications were compared in the treatment of childhood absence epilepsy. So that includes ethosuximide, or what we sometimes call Zerontin, valproic acid or Depakote, and lamotrigine, which the brand name is Lamictal. Each of these were tested as monotherapy and put head-to-head in a controlled trial involving 453 children with newly diagnosed childhood absence epilepsy. The doses were titrated as to clinical response. Ethosuximide and valproic acid doses were up to 60 milligram per kilogram per day, while lamotrigine doses were up to 12 milligram per kilogram per day. In this study, ethosuximide and valproic acid were significantly more effective as compared to lamotrigine for the outcome of seizure control. At 16 to 20 weeks of initiation of therapy, freedom from treatment failure was 58% for ethosuximide, 66% for valproic acid, and 39% for lamotrigine. These differences persisted at 12 months after treatment initiation. The most common reason for the treatment failure with lamotrigine was a lack of seizure control. Valproic acid was associated with higher rates of attentional dysfunction and adverse events compared to ethosuximide. Attentional problems occurred in 49% of children on valproic acid versus 33% on ethosuximide. Discontinuation due to adverse events was most frequent with valproic acid, followed by ethosuximide lamotrigine. The mechanism in which ethosuximide works is that it targets those T-type calcium channels that directly modulate the aberrant thalamocortical oscillations that we see during absence seizures and childhood absence epilepsy. And that helps make sense of the biologic plausibility working on that helps make sense of why the medication is so effective in controlling absence seizures. And it gives us a mechanistic understanding of why the treatment is effective. The American Academy of Neurology and the American Epilepsy Society recommend ethosuximide as optimal initial empiric treatment for childhood absence epilepsy. Valproic acid is also an effective medication, but it does have significant side effects, including weight gain, hair loss, and other issues, and thrombocytopenia, increased risk of bleeding. The side effects are a little worse than ethosuximide, so that's why the AA and American Epilepsy Society prefer childhood absence epilepsy prefer ethosuximide over valproic acid. With ethosuximide, there can be side effects such as GI upset. There's a lot of patients that feel they're just not their stomach feels upset with ethosuximide, and sometimes that can be a limiting factor with children. Valproic acid is recommended if generalized tonic-clonic seizures coexist with the absence seizures, but it is associated with more adverse effects, like I mentioned. The mechanism of ethosuximide is really focused on those absence seizures by acting on those T-type calcium channel and T-type calcium channels, and so it doesn't really help with generalized tonic-clonic seizures, which come from a different mechanism. But valproic acid can be helpful there. Lamotrigine, like I mentioned, is less effective for seizure control overall, but you can try it at times. It does seem to have some effect, just not superior to valproic acid or ethosuximide when it comes to the absence seizures specifically. Carbamazepine and phenytoin and other oxcarbazepine are generally contraindicated as there's a thought that they can worsen absence seizures. And there's no evidence that childhood absence epilepsy resolves without treatment in most cases. Most children achieve seizure remission in adolescence, but up to 25% may have persistent seizures or develop generalized tonic-clonic or myoclonic seizures. The majority of children with childhood absence epilepsy do go on to live normal lives, but there is a subset that may experience ongoing cognitive and psychosocial challenges, so we do need to bear that in mind. And approximately 15% of patients who are initially diagnosed with childhood absence epilepsy, who initially remit during their childhood years, may end up developing juvenile myoclonic epilepsy as teenagers. And I made a separate video about juvenile myoclonic epilepsy that you can see on my channel. When it comes to absence seizures and absence epilepsy, like I mentioned, most of these seizures are 5 to 30 seconds, but there can be times, very rare times, but I've seen where absence epilepsy can go on for hours and hours. And this is something we call absence status epilepticus. Now, status epilepticus is often associated with brain injury. We have operational definitions of where we think status epilepticus is the time it takes that it's more likely to be prolonged and the time at which it's more likely to cause brain injury. When it comes specifically to absence status epilepticus, we think if the seizure goes on for more than 10 to 15 minutes in duration, it's going to be harder to control and more likely to be prolonged. But we don't have any evidence that prolonged absence status epilepticus leads to brain injury, and that's important to note. Although you do have alteration of consciousness during your absence seizures, and so you really have to be mindful of the risk of injury from other causes if you have absence seizures. You have to, for older individuals, not necessarily the childhood onset school-age children, but older individuals that have absence seizures, you got to be thinking about what happens if they are driving or on a bicycle on the road and they experience an absence seizure. If they're swimming and they have an absence seizure. What's really important is to think about the context in which a seizure happened and the likelihood for injury to happen if the seizures were to occur in that sort of situation. That's kind of what we need to think about overall with epilepsy when we think about seizure precautions. Common misconceptions regarding childhood absence epilepsy include the belief that childhood absence epilepsy is entirely benign and that the seizures are the only concern. In reality, neuropsychological deficits can be frequent. The term childhood absence epilepsy does not strictly suffer from reification, but it's more important to recognize that it's part of a spectrum and related syndromes, such as juvenile absence epilepsy, which is distinguished primarily by age of onset and also seizure type. So we have to sort of recognize what these syndromes are and what's the best way to treat for them. So I hope this video was helpful for you. If you liked it, please like this video and subscribe to the channel if you're looking at this on YouTube. I thank you for your time, and I hope you have a wonderful day.